about today I'm going to talk about the integrated motivational-volitional model of suicidal behavior. So like I said, it's kind of a didactic, kind of a journal club, because I was basing this, all of this on pretty much one article, kind of 1/2 articles. And a little bit towards the end, I was able to pull some complementary studies to show just a little bit more breadth to it. All of the links or all of the resources are on the reference slide, and the article itself, the one that's referenced on this slide by O'Connor and Kirtley, was uploaded to iEcho. So you should be able to find that along with the PDF of the slides for today. In a variety of clinical settings, obviously from mental health to primary care, having an awareness of suicide risk and risk vulnerability factors and a knowledge of a model around suicidal behavior can inform clinical care and is likely to be helpful in organizing a clinical formulation and possible interventions with our individuals that we work with. So globally, suicide was the 4th leading cause of premature mortality for persons aged 15 to 29 years old in June of 2021. In 2021, in the US, over 48,000 individuals died by suicide. Over 12 million adults in the US have thought about it. 3.5 million made a plan, and 1.7 million made an attempt. The number of deaths by suicide from 2021 to 2022 increased by 2.6%. And I start here because the integrated motivational-volitional model of suicidal behavior, which I think I'm going to try to just say IMV, because that is a whole mouthful. This model is a theoretical model for conceptualizing what pushes people along the path from just thinking about suicide to acting on those thoughts. So this whole graphic is, so it's in the article itself, and it looks at 3 different phases, from the pre-motivational phase up through the volitional phase. So before even thinking about suicide, before having an event that would cause negativity, all the way through the actually acting on thoughts. It starts with that pre-motivational phase, which is comprised of a diathesis stress model, so predisposition plus stress. So diathesis is a constitutional predisposition or tendency, like biological, genetic, or cognitive vulnerability factors. So examples would include personality characteristics. One that is noted highly in the research is actually socially prescribed perfectionism. Socially prescribed perfectionism is described as the perceived need to attain standards and expectations prescribed by somebody other than yourself, so significant others. A belief or perception that significant others have unrealistic standards for them, that those individuals are evaluated by the significant others stringently, and that the significant others exert pressure on them to be perfect. So there's this strong need for perceived approval from those significant others and a strong sensitivity to criticism. So a perception that failing to meet the standards will lead to isolation, humiliation, potentially entrapment, and hopelessness. And those who are rated highly on socially prescribed perfectionism do tend to report higher levels of defeat and entrapment. Also in the diathesis piece is the environment and life events, which sometimes kind of overlap in my brain, just because they both can play a role in epigenetics and general stress. So things like socioeconomic deprivation, impact of maybe an economic crash or some type of an economic setback, cultural variations in response to social discord, amount of discrimination experienced throughout the lifetime, cultural variations in how distress is expressed or how suicide is viewed in terms of acceptability, access to appropriate care, acceptability of seeking mental health care, so basic social determinants of health type stuff. And the idea is that these pre-motivational factors can have an effect on suicide risk through their influence on the various other constructs in the other phases. Specifically, they influence an individual's response to defeat or humiliation, which brings us to the next phase of this model. So the motivational phase occurs after something that it results in defeat and humiliation. So what takes a person from an event where this is felt, because not everybody progresses beyond that. Some people experience an event and let defeat, humiliation, pain just kind of roll off of them, and entrapment is not inevitable. But the theory is that threat to self-moderators are the things that influence the progression from, this feeling of defeat and humiliation to a feeling of entrapment. Threat to self moderators are things like memory biases, rumination, social problem solving, a perceived inability to deal with challenging situations, and or an actual skill deficit. So as clinicians, our role at this phase might be to help an individual identify and challenge some of those threat to self moderators, help them recall times that they've overcome adversity in the past, help them increase their awareness of their rumination, identify triggers for ruminating behaviors and to reduce it, all of which might help them to feel less of a sense of entrapment. But when they do get to a phase of feeling a sense of entrapment, so truly trapped, that like there's an inability to escape from whatever that situation is, that could be external or internal. So external might be loss of employment, feeling like they're not going to be able to find another job, long-term health impediments, feeling like this is the rest of my life now and there's no getting over this. I won't be able to function the way that I used to. Internal might be a sense of being unable to resolve an internal feeling of distress. Entrapment can be driven by self-talk and also a personal assessment of the current situation. So it might be partially realistic, but it also might not be. An individual's appraisal of the situation might be distorted, exaggerated, or they might just not be able to identify possible solutions independently. People even engage in kind of defeat behaviors that keep them in this cycle of feeling trapped. And standard CBT techniques focused on cognitions, beliefs, and behavioral activation could be important in this phase to really help engage with patients. The final part of the motivational phase is a transition from entrapment to suicide ideation and intent. The authors posit that the presence or absence of certain motivational moderators will increase or decrease the likelihood of this occurring. So think back to Sarah's didactic from a couple weeks ago, where she covered the Surgeon General's advisory around loneliness, because this relates to motivational moderators. So when positive, people may have reasons for living, positive future thinking, be able to think about how to adapt their life goals, despite a feeling that they feel kind of trapped in. But if they can identify ways to adapt their goals or adapt around their goals to still meet them, then that can help pull a person out of that sense of feeling trapped. A sense of belongingness and strong social connections, all of those buffer that transition from entrapment to ideation. Conversely, when people feel disconnected, feel a thwarted sense of belonging, like their resilience has been depleted, or their goals are unattainable, or even that they're now becoming a burden on others. All of those might increase the likelihood of developing suicide ideation intent from that, from entrapment to then ideation. The final phase describes the transitions from thoughts to actions. And we're going to talk a little bit about motivational or volitional moderators, which get a person from the ideation and intent to actually acting on it. So this is kind of the general list of volitional moderators identified by O'Connor and Kirtley. First is access to means. This is an environmental moderator. You can have it in your environment or not. And if you glance at the graphic in the lower right, you'll notice that access to means is also in my opinion, very closely related as an issue of concern to impulsivity, especially if there is a presence of a more lethal mean and or substance use. So two of the studies referenced in one of the articles used noted a large portion of suicide attempts occur within 5 to 10 minutes of the decision to act. So this makes impulsivity and access quite literally a deadly combination. A social moderator could be exposure to death by suicide or suicidal behaviors, inappropriate representations of suicidality, so things like glamorizing, or overexposure on social media, which we've talked about before in the past, with certain social media platforms having heavy suicide content for particular age groups of individuals, and how that could be obviously pretty dangerous. A 2015 study concluded that compared to those who just think about suicide, those who act on their thoughts were significantly more likely to have a family member or close friend who had either engaged in non-suicidal self-injurious behavior or attempted suicide. And they were significantly more likely to be more impulsive and rate themselves as fearless about death. Another volitional moderator is around capability. is that person fearless about death? Like, so fearlessness about death can obviously be a risk factor. Are they engaged in detailed planning, which could increase risk? Are they starting to maybe even engage in some cognitive rehearsal processes? Also, do they think that they can endure a few moments of intense pain to achieve the desired end state? And pain and physical pain sensitivity and endurance, this one's really tricky for me because we know that individuals experiencing chronic pain, chronic extreme pain, are at a higher risk for suicide. So it's not that they feel like they can endure it, but in fact, suicide is the option to get rid of the pain. So obviously, none of these are universal, and you really have to look at the individual circumstances. But what the authors are pointing to with this is that people with a history of non-suicidal self-injurious behavior and previous suicide attempts, this is correlated with later suicide attempts. So they're really pointing to a habituation factor. So not only in regards to the planning and the cognitive rehearsal, but to self-inflicted pain and thoughts of dying. So very short and sweet. In summary, the integrated motivational-volitional model for suicidal behavior doesn't address whether certain combinations of factors across the three phases result in higher or lower risk trajectories, but it does give clinicians some potential targets for intervention at each phase and ways of conceptualizing risk and risk progression from just a negative feeling, negative event, up through ideation and then into actions. Some research has been done around the model and is generally supportive of the associations between defeat, entrapment, and suicidal ideation, as predicted. And there's actually a systematic review that I just published online recently. And what was interesting is that in this review, they found that only 3 studies looked at all 3 phases within the study. So obviously, there's a lot more research that needs to be done, but there's quite a bit of research going into various aspects of the model and just looking at them at a kind of more micro level. For example, 2019 study investigated the relationship between social comparisons, suicide ideation, defeat, entrapment, and socially prescribed perfectionism and resilience. Another looked at rumination styles, hope, and suicide ideation. And they found that hope weakened the relationship between entrapment and suicide ideation. So there's, I think, also important to remember that there's always limitations to any of the research around suicide for very good, logical, ethical reasons. So kind of worth taking with a grain of salt and taking what's useful with your patients and leaving the rest. But seems like an interesting model, kind of gets us through all of those pathways and something just to keep in mind, maybe talk about. And the top one is the main article that I referenced, but then a couple other things that are kind of interesting.